Okay, thank you very much, Grace, for inviting me for this interesting meeting. My computer recovered from jet lag, so I start my talk. Okay, so my talk is embolization by deeply seated brain tumors. So as for the embolization brain tumor, usually we do the pre-surgical embolization. But if we could completely embolize the tumor, we could cure the tumor and we could do the mass reduction by embolization. So as for the selection of the embolic agent, usually I use NBCA or Onyx, but in Japan, only NBC is available for brain tumor embolization. As for the particular embolization, only if I embolize from this area, only the supplying area is only embolized. But if we use pressure cooker technique from the feeding artery, we could deliver the embolic agent to the every feeders via anastomotic channel. So we could do good embolization from the single feeders. So this is a case intraventricular meningioma. You could see tumor stain here. And this patient is supplied on the posterior choroidal artery. So I embolize this feeding artery on the coil. But if I put the coil for this feeding artery, almost the entire part of the tumor is embolized. So I'm waiting the effect of the embolization of the brain tumor. I waited 1 month and 4 months, 6 months, 8 months. So this is before embolization. This is 8 months after embolization. So tumor size reduced, and it size of the gamma knife. So I send this patient to the gamma knife without a surgical removal. And this is another case of the meningioma. It's easier to remove this, looks easy to remove this meningioma, but check the venous outflow. This area is completely occluded, and the suprascital sinus is connected from the diploic vein to here. So if we do the craniotomy at this area, I think we occlude the sinus. So it's dangerous. So I did the embolization for this case. So I navigate the microcatheter to embolize. So it is pre, and it is 6 months later. We could find the remarkable side reduction by only embolization. And this is a skull-based tumor, juvenile angiofibroma. So my ENT surgeon tried to remove this tumor without embolization. She massive bleeding, so he quit surgery. So he asked me to embolize this tumor. I did this from angiogram from left internal maxillary artery, this left ascending pharyngeal artery. So I navigated the, okay. So I navigated the marathon into the, from the internal maxillary artery to the wedge position. And I injected 20% NBCA from the wedge to microcatheter.
High dilution? High dilution?
20% NBCA. So I put a balloon to the internal carotid artery to prevent the migration of the NBCA into the ICA. So I'm injecting the NBCA 20%. Totally, we could inject the 2.5 milliliter NBCA from one pellicle.
For single session?
In single session.
No.
Only single session, 2.5 syringe. So NBCA go to the everywhere through the anastomotic channel.
Is it the best injection you ever did?
No.
Because I've never seen so good penetration.
Okay, I should rate the best injection. Okay, this is better one.
This is Japanese blue.
special NBCA.
Fantastic.
Fantastic. High illusion.
And this pellicle is embolized. And still another pellicle, and direct puncture, just as Jack showed yesterday. So from percutaneous puncture and injected the NBCA. So this is a photo of the after injection of the NBCA. So my ENT surgeon is very happy. He could remove this tumor without less than 200 millimeter bleeding. And this is another meningioma. This is 80 years old male patient have a gait disturbance. This is a typical meningioma. So I don't want to remove this meningioma because patient is already 80 years old male. So also I did the embolization for this tumor. So I show this is my best embolization. I navigate the marathon to the deep into the middle meningeal artery, and from the wedge position we start the injection. From this is that 70% NBCA. 17, not a 70. And a little bit pull back and inject again. And start NBCS penetrating to the tumor. Hmm? And it into the anterior falx artery. And still I continue injection.
It's continuous injection.
Yeah, pause. Yeah, pause. And this is pause. And this injection again. And we shall go to another channel. And finally, it into the medial part of the tumor. Okay. So this is a photo after embolization of the NBCA. The lateral part of the tumor is not embolized, but this area is supplied from the pial branches. But maybe 18% tumor is embolized by NBCA.
Did you cut the catheter?
No, just pull back.
You could pull out?
Yeah, 70%, 17%.
Very long.
Oh, no.
And this is a post. But the patient is fine for 1.6 months, 1 year to 6 months, but regrowth aneurysm, patient died finally.
Why?
Recurrence of the tumor. This is a malignant meningioma, I think.
So why not remove it?
Yes. So this is a case of the CP angle meningioma. It is maximum diameter 6 centimeter. I want to remove this tumor from the suboccipital approach, but this patient have feeders from the inferior lateral trunk and the meningohypophyseal trunk. So if I approach from a suboccipital route, the all feeding arteries, I could finally coagulate this feeding artery. So before the surgery, I want to embolize this feeding artery. But to navigate the microcatheter is not always easy to meningohypophyseal trunk and inferior lateral trunk. So I used, first I used marathon, but marathon doesn't go. So I use Carnelian marble. This is a double catheter system. One is 2.7 and another one is 1.5. And use a balloon to turn the microcatheter. Finally, we could I could succeed to the microcatheter from here to inferior lateral trunk to the inferior lateral trunk to here, and inject the NBCA. I don't want to use a plug and push technique from this area because patients sometimes cause cranial palsy. And embolize the other meningeal feeders, and final angio from external carotid system and from the internal carotid system. So this is a post-embolization MRI. These areas embolized and completely necrosed. So removal of the tumor is not so difficult from suborbital route. I could completely remove this tumor. Patient caused moderate face palsy, but completely recovered, and the patient still fine without any recurrence. But to navigate the microcatheter to the infralateral trunk or meningohypocystole, not always easy. So this is another case. This patient is a 46-year-old male. Patient have impairment of cognitive function and gait disturbance. So this is a petroclival meningioma, and the maximum diameter is 43 millimeter. So feeding artery from the middle meningeal artery, and also from the infralateral trunk and the hypophyseal trunk. So at this time, Professor Matsumoto, he invented a very good catheter. This is the deflector. I believe this is the best microcatheter, hybrid type of microcatheter, much better than Marathon. So we could navigate to this catheter.
What is the distal part? How big is it?
Hmm?
How big is the distal part of this catheter?
1.3.
1.3.
So I navigate this microcatheter to the basal tentorial branch of the middle meningeal artery. So I could succeed to navigate the microcatheter to deeply to the middle meningeal artery branch. So I start injection of the glue, NBCA. Look, so NBCA go to the infralateral trunk to the retrograde fashion. From middle meningeal artery to the infralateral trunk to the retrograde fashion. So I could embolize the infralateral trunk from middle meningeal artery. So and I obliterated another meningeal feeders, and this is embolization from other meningeal arteries. Move is working.
Yes, yes.
Is it working?
Not now.
Not now. Not now. Not now.
At the beginning,
Oh.
yes, now.
Okay. So this is another injection from the branch of the middle meningeal artery. This is microcatheter is deeply inside of the feeding artery, and they injected 17% NBCA from feeding pellicle. This is the injection of the NBCA. And still a feeding artery from the petrosal branch of middle meningeal artery, but this branch is very dangerous to cause facial palsy. So I obliterated this branch by putting coils. And embolization finished. And I removed this tumor from the classic route, petrosectomy, and I removed this tumor from transpetrosal approach. So if we use the pressure cooker technique, we could embolize from the another feeder to every feeders. If we could keep the position of the microcatheter deeply wedged position. And maybe possible to embolize the entire feeding arteries from the single feeding artery, even in the brain tumor, especially for use for the skull-based tumor. But it is very dangerous sometimes because these branches are feeding branch of the cranial nerves. So my conclusion is it's possible to embolize access difficult feeders from easier feeders using pressure cooker technique. Also, it may be possible to embolize from single feeder to all feeders. If this technique is established, brain tumor growth may be controlled by only embolization. Okay, thank you. So,
Do you have some complications for the nerves?
Yes, we have sometimes.
Some-
Not sometimes. Not very often. But this patient caused a forced cranial nerve palsy after embolization, but it recovered.
So is there any further treatment after the embolization?
Mm.
So you resect it or
Yes.
just left it? Because you mentioned that one patient died for the malignant meningioma. So
Oh, yes.
that case,
He is 80 years old male.
okay,
So I think it is not indication of that tumor removal.
okay. So most of the cases, you after the embolization,
Yes,
you
for
still
skull-based
remove
tumor,
it.
I remove.
Okay.
One comment.
Mm.
Well, I use also the hyperdiluted NBCA to the tumor with the same, but also the onyx.
Mhm.
The only difference with onyx, when I talk with the neurosurgeon, is not easy to remove.
Yeah,
the
that's right.
cast
That's right.
Onyx.
That's a good point. As for the removal, NBC is some obstacle because tiny channels filled with onyx. So sucking the tumor is not so easy. Just onyx network remains. But only no. If we use NBCA. So, but the concentration of the NBCA is 70%. Not so difficult to cut only cedars. But onyx is better. But the point of why I don't use the onyx is onyx is not available, not allowed to use for brain tumor in Japanese government, only for ABM and dural ABF.
When I use the onyx in tumor, every time you are the rupture of a stroma, because the MCO, a high blood pressure, you are rupture. Don't free. You continue to push and you close. Every time you bleed. You are contrast. Don't worry. Push.
Okay. So may I change to the, let's see. Okay, another topic. Let's see. Oh. Let's see. Oh. That. This one. Oh. Which one? From the beginning is here? Oh, I can't understand Spanish. This one? Okay. So next talk is endovascular treatment of dural ABF around the conference using a sinus protection balloon. The Copernic is not available in Japan, I say. So dural ABF around the conference is not so easy, difficult to cure, to keeping the patency of the conference. And need to use multiple sinus protection balloons for diameter conference. I tried four cases, but I showed two cases. This is first case. Let's see. Go back. How can I? Let's see. Go back. Oh. This is a patient was found in the CT abnormality, and you can see the abnormal finding. And also, this is the 3D array. You can find the shunt, just left corner of the conference. Here, you can see that some channel that is maybe a shunt point is here. And the sinus is very enlarged, and the patient doesn't have a straight sinus, and the patient have a falcine sinus. And this is a CT scan. And this is rotational angiography. You can see the shunt point close to here, this area. But only single balloon, it is very difficult to prevent the sinus.
Which balloon?
I use a Kaneka balloon. I show you. That is Japanese company making Kaneka. So this is another view. This is the internal carotid injection. There are feeders from PCA, dural branch, the bit of shifter supplying the feeding artery. And also this is right carotid, external carotid injection. And the shunt is very close to the left side of the conference. But anyway, many high flow shunt, many feeders, and have lot of high flow shunt. And the patient have a retrograde venous drainage. This is the internal carotid injection. Patient have dural branches from the ICA and also from PCA. So this is the ECA feeding artery. This is left ICAG feeding artery from PCA branches and dural branches. And from left ECA, middle meningeal occipital artery, feeding arteries, and also ascending pharyngeal supplies the feeding artery. Initially, I try to navigate the seven French guiding catheter from transvenous route. But I failed to.
More water, more water.
Okay.
Give him beer.
You want
Yeah, it's better. No. Maybe Spanish wine is better for me. And from transvenous route, you could navigate the seven French guiding catheter to the shunt pouch. But if I inflate the balloon at this area, balloon is pushed out because of the high flow. So this is a Kaneka balloon. This balloon is not for the sinus occlusion, but usually this balloon is a 7 by 7, but the maximum diameter is 14 by 30 millimeter.
Yeah.
30 millimeter. Length is 30, and diameter is 14 millimeter. This is the angiogram. And initially, I tried to navigate the seven French guiding catheter from the transvenous route and inflate the balloon and obliterate this shunt pouch. But if I inflate the balloon is washed out because of the high flow. So I abandoned to transvenous embolization. So I approached from transarterial side. But if I inject the onyx from a transarterial route, onyx will go to the sinus. So I must protect the sinus migration of the onyx. So I inflate the single balloon from the left side, but only single balloon doesn't occlude the outlet of the shunt. And I navigate the septa deeply into the right middle meningeal artery, and I inflated, use two balloons to obliterate the shunt pouch. And I injected onyx from the balloon inflated septa. This patient have a lot of feeding arteries. Total onyx is 13 milliliter. Onyx is necessary to occlude this shunt. I injected the 30 millimeter onyx from 30 minutes. So onyx is a reflex to the feeding arteries, every feeding arteries. And still onyx is going, but still going to back to the feeding artery. Go back to the feeding artery. And at this time, onyx started to enter the shunt pouch. This area is shunt pouch, and this onyx is going to migrate into the sinus. But here is a balloon, so this balloon prevents from the migration of the onyx. Still, I continue the injection of the onyx. And the onyx is refluxing to another feeding artery, and still continuing injecting onyx.
What is the speed of your video? It's 3 times accelerated or 5 times?
This is, I think, 8 times.
8 times.
Yes. Yeah, so I've never used the onyx 30 millimeter in one session. I'm scared, but I must push, because if I stop the push, the onyx, this shunt doesn't cure. So I continue pushing the onyx. So finally, I could obliterate the shunt. And using the 13 millimeter onyx 18, I could completely obliterate the shunt. So this is 2 balloons. One is here. This balloon obliterated the outlet of the venous pouch. And this balloon is to stabilize this balloon. So by using 2 balloons, I could stabilize this balloon and could obliterate the shunt. And this is a septa, inflated septa. I injected the onyx from this septa to the entire dural AVF. And I show another case. This is a 40-year-old female patient has pulsar tinnitus. And this is MRA. Patient have a shunt around the conference. This is angiogram from left external and lateral view. This is a very high flow shunt. And this is right occipital artery. This is shunt. And left external carotid angiogram. But shunt, in this case, shunt is not on only single shunt. Another shunt around the conference. This is the occipital angiogram. And this is ascending cervical. From ascending cervical, we could find the shunt pouch here. And this is the bilateral internal carotid angiogram. Okay. So this is angiogram from the right external. And this is from the left external. And this is from the occipital artery. And this is from the feeding artery from the occipital artery. And this is the feeding artery from the ascending pharyngeal artery. So shunt is located below the conference and around the conference. So I used, and this patient have also destroyed of the skull bone. And if we wait a lot, maybe this bone is totally destroyed. So maybe it will be possible to direct puncture to this shunt. But the patient is complaining pulsar tinnitus. I try to use onyx embolization. So shunt located this area. So I navigated the balloon to from the left side, and from the arterial side, I try to inject the onyx. But shunt is very big. So I show movie. This is the left angio. This is lateral view. This is so I never initially I used the marathon, but marathon passed through the shunt, and the marathon entered into the venous pouch. So I changed the microcatheter from marathon to a SL10 to put a coil, to use a coil. And I could succeed to navigate the microcatheter through the shunt point to navigate into the shunt pouch. So microcatheter is navigated through the shunt point to the shunt pouch, artery to venous side. And this is a navigated balloon catheter to obliterate the orifice of the shunt pouch. But anatomy of the conference is not regular. So some part is very narrow. So initially I put the coil because the onyx stay without migrating to the sinus. But only single balloon, I couldn't completely obliterate the shunt pouch, outlet of the shunt pouch. I navigate another balloon. At this point, this is eight times earlier. Eight first mode of the movie. And put another balloon to here. By two balloons, I could obliterate the shunt pouch and put microcoils to stabilize the onyx. And at this condition, I start to inject the, but still angiogram showed some migration of the contrast. But I start the injection. Partially, small amount of the onyx entered into the sinus. But after that, onyx stay inside of the shunt pouch. And make a plug at the shunt pouch, I could continue injecting onyx. So I could inject onyx to the retrograde fashion to the feeding arteries. So onyx injecting to the retrograde fashion to the feeding arteries.
Not the fed balloon.
Not the deflate balloon.
Never.
Never. Because shunt pouch is very wide. So if we deflate the balloon, it has a chance to the onyx migrate into the sinus.
But you were still within the dural pouch.
Oh, yes,
right?
yes,
Injecting through the microcatheter.
Yes.
Within the dural pouch.
yes. So this is a transarterial, but a transvenous injection. So I deflate the balloon, but still small shunt is located at the left corner of the transverse sinus. So still I navigate the microcatheter to the from the left middle meningeal artery and inject onyx under balloon protection. And onyx is going to filling the shunt pouch around the left transverse sinus. And I deflated the balloon, shunt is completely gone. And
And the sinus is open? Still open?
yes, of course,
Okay.
of course. This is a cone beam CT. The onyx located in the bone. And our strategy is two balloons and obliterate the shunt pouch and navigate the microcatheter from the meningeal artery through the shunt point and introduce into the shunt pouch and put two coils and start the injection from the this pouch to the onyx. And this pouch is obliterated, but still small shunt is remained around the transverse sigmoid corner, transverse SSS and transverse corner. So I navigate the microcatheter from left side. I inject the onyx and completely shunt is gone. Okay. So sinus protection using balloons and flow control using coils and embolization from the bilateral MMA for multiple shunt. So my conclusion is it's possible to treat the dural ABF around the conference, keeping the SSS and TS patient using multiple protection balloon catheters. Thank you for your attention. Any questions? Okay, Divan, please.
least in the second case, I guess the fistula was in the junction between the torcular and the embryonic tentorial,
Oh, yeah.
occipital
Yeah,
sinus.
yes,
right?
I agree.
Yeah, but you have a very good position within the pouch. You may even inject pouch if you have a very good control of the sinus protection. But I guess you don't have Copernic RC available in Japan, right?
Not available in Japan.
No. Yeah, but if it were available, then it would be easy to use two of them
Yeah, I think so.
and protect this not only torcular but also the orifice of the so-called occipital sinus pouch.
But I don't know the maximum size of the Copernic. Is that
10 by 80.
10 by 18?
Two 10 by 80 will make it 20. Then it will cover probably everything.
18 millimeter?
But although they claim that it goes up to 10, I remember that I've inflated up to 14.
14
Yeah,
in
14
diameter.
millimeter, yeah.
Yeah, that's big. That's enough. If I use a Copernic on the single barrel, it's possible.
Just give a short comment. If you can put a double lumen balloon in the pouch that I did before, then
Yeah,
you can.
I did.
Yes, you can put a couple of coils and then you don't need to push so much onyx. You just occlude the pouch. This is also an option.
Yeah, that is another option. I did. I have an excellent 4 case, and I used the same technique as you showed. From the retro. Yeah, from the I did. From the retrograde fashion, I navigate the micro balloon from venous side and operated outlet and inject onyx.
You made my day.
Okay. Okay, thank you very much.